In this presentation, we will be discussing deep vein thrombosis treatment and prophylaxis in the pediatric population. I have no conflicts of interest to disclose. Here are the learning objectives for today's presentation. We will discuss the epidemiology and pathophysiology of deep vein thrombosis in pediatric patients. 2. Review guideline recommendations for the treatment of pediatric deep vein thrombosis. 3. Analyze the current evidence for use of direct oral anticoagulants in the pediatric population. And 4. Identify hospitalized pediatric patients that may benefit from the use of DVT prophylaxis. Deep vein thrombosis, or venous thromboembolism, is a rare event in the pediatric population, but has the potential for significant complications including pulmonary embolisms, cerebrovascular events, and post-thrombotic syndrome. The incidence is variable in the pediatric population, with up to 0.14 cases per 10,000 children in the general population. However, the incidence can be up to 1,000 times increase in hospitalized children, with greater than 58 cases per 10,000 admissions. Among hospitalized children, there is a bimodal distribution of DVTs, and they are most commonly seen in the neonates as well as adolescents. The low incidence of DVTs in pediatric patients compared to adults is due to differences in the underlying physiology between children and adults. DVTs occur when one or more components of Virchow's triad is activated, which include a state of hypercoagulability, endothelial injury, and/or changes in hemodynamics. Compared to adults, children have an overall decreased activity level of thrombin, which is a crucial enzyme in the clotted cascade as it converts fibrinogen to fibrin, as well as increased antithrombotic potential of the vessel wall and less accumulated damage to the endothelial wall, which all contribute to the lowered overall incidence of VTEs in the pediatric population. Unprovoked VT in the pediatric population is extremely rare, with more than 90% of pediatric VTE cases being associated with at least one acquired or congenital risk factors. The most common risk factor for development of DVTs in hospitalized children is the presence of a central venous catheter, which can account for up to 90% of VTEs in neonates and greater than 50% of cases in pediatric patients. Other acquired risk factors may include transient factors such as infection or surgery, and persistent factors such as congenital heart disease or systemic lupus erythematosus. Many of the congenital risk factors are associated with a deficiency in various factors such as antithrombin 3 deficiency or protein C or S deficiency. Next, we will move on to the discussion of the treatment of DVT in pediatric patients. Recommendations for the management of venous thromboembolism in children have been outlined by the American Society of Hematology in the 2018 guidelines. The guidelines strongly recommend that pediatric patients with symptomatic DVT or pulmonary embolism should be treated with anticoagulation, as DVTs in hospitalized pediatric patients can often be life-threatening. On the other hand, the guidelines suggest either using anticoagulation or no anticoagulation in patients with asymptomatic DVT or pulmonary embolism, and that the decision should be made on an individualized basis. There is insufficient data exploring the relative risk-benefit of the use of thrombolysis in the pediatric population, and thus the panel suggests against the use of thrombolysis in pediatric patients with DVT or submassive pulmonary embolism, defined as those patients that do not have hemodynamic instability. Conversely, the guidelines suggest that thrombolysis may be utilized in children with pulmonary embolism with hemodynamic compromise, which can be life-threatening and require immediate intervention. As the presence of a central venous access device is the leading cause of DVTs in pediatric patients, the panel makes specific recommendations on management of a central line-associated thrombosis. The panel suggests not removing the line in those patients that continue to require venous access, as insertion of another line can be thrombogenic, but recommends removal of the device in those patients that no longer require central access. Further, it is suggested that removal of the device should be after a few days of anticoagulation to avoid the emboli that can lead to pulmonary embolisms or paradoxical strokes. For pediatric patients that require anticoagulation treatment, the guidelines refer to the use of unfractionated heparin, low molecular weight heparin, fondaparinux, or vitamin K antagonists such as warfarin as potential options, with a specific recommendation to utilize either low molecular weight heparin or warfarin for patients with symptomatic DVT or PE, taking into account patient preferences, available resources, and underlying conditions and comorbidities. Here is a quick overview of the various anticoagulation agents that may be utilized in the pediatric population as we go into more details of each agent. During this presentation, we will be focusing on the parenteral agents including unfractionated heparin, low molecular weight heparin, and fondaparinux, as well as oral agents including warfarin, rivaroxaban, and dabigatran. When choosing an anticoagulation agent, it is important to weigh the thromboembolic risk as well as the associated bleeding risk for each agent. Further, additional considerations in the pediatric population include the assessment of available evidence, as data for the newer anticoagulation agents are still limited, as well as assessment of available formulations and need for therapeutic drug monitoring, which can be invasive and a burden for pediatric patients. Next, we will be reviewing the various parenteral anticoagulant agents. Unfractionated heparin is a pentasaccharide that binds antithrombin to inhibit factor IIa or thrombin and factor Xa in the coagulation cascade. On the other hand, low molecular weight heparins such as enoxaparin is a shortened polysaccharide approximately one-third the size of unfractionated heparin that also activate antithrombin but predominantly inhibit factor Xa, as the smaller fragments are unable to simultaneously bind antithrombin and thrombin as seen with unfractionated heparin. Unfractionated heparin is primarily given as an intravenous bolus followed by continuous infusion, with younger patients requiring a higher unit per kilo dose. The continuous infusion rate is adjusted to maintain a goal anti-10A level between 0.3 and 0.7, or may alternatively be monitored using activated partial thromboplasmin time, or APTT. The optimal assay to monitor heparin therapy has not yet been fully established, but APTT levels may be affected by factors that are not associated with the level of actual anticoagulation. Due to the advantage of having a short half-life and rapid onset and offset of action, as well as its reversibility using protamine, heparin may be preferentially used in acutely ill hospitalized pediatric patients, especially in the post-operative setting or those requiring potential surgical interventions. Certain situations may warrant the use of an alternative agent to heparin therapy in the acute setting. The guidelines recommend the use of a thrombin inhibitor such as bivalirudin when the heparin alternative is needed, such as in heparin-induced thrombocytopenia, which is a very rare event in pediatric patients, or an inability to get therapeutic levels of anticoagulation in heparin despite increasing doses. Low molecular weight heparin, such as enoxaparin, is administered as a subcutaneous injection every 12 hours with variable dosing according to the patient's age and weight. The dose is commonly modified according to anti-10A levels with a goal of 0.5 to 1 and should also be adjusted in the setting of renal disease. Compared to unfractionated heparin, low molecular weight heparins have a longer half-life as well as a more predictable dose-response relationship, which makes it preferable for long-term therapy. Similarly to heparin, protamine may be used to reverse the effects of low molecular weight heparins, although it is important to note that protamine here has a partial reversal effect. In discussing low molecular weight heparins, it is important to note differences in dosing for neonates. Younger patients require higher doses of low molecular weight heparins to obtain a therapeutic level, and higher starting doses have been investigated for the neonatal population. Studies have shown that an average maintenance of up to 2.37 mg per kilo per dose may be required to obtain a goal anti-10A of 0.5 to 1 in patients less than 2 months of age. Based off of these studies, alternative dosing of low molecular weight heparins have been considered for neonates, with a higher starting dose of 2 mg per kilo per dose for premature neonates and 1.7 mg per kilo per dose for full-term neonates. To wrap up the discussion on heparin and low molecular weight heparins, there are a few pediatric-specific considerations to remember. As previously mentioned, due to underlying physiologic differences between children and adults, including the reduced capacity to generate thrombin, pediatric patients may respond differently to unfractionated heparin as well as low molecular weight heparins when compared to adults. Pediatric patients, especially neonates, have lower levels of antithrombin, which necessitate the age-specific, higher milligram per kilo dosing in this patient population. Additionally, it should be noted that although anti-10A monitoring is routinely performed in pediatric patients, the anti-10A therapeutic ranges have been extrapolated from adult data, and there may be significant age-related differences in anti-10A activity. The last parenteral anticoagulant to be discussed is fondaparinux. Fondaparinux is a synthetic pentasaccharide that also binds antithrombin similar to heparin and low molecular weight heparin, and lead to selective inhibition of factor Xa, inhibiting the downstream clotting cascade. Like low molecular weight heparins such as enoxaparin, fondaparinux is given as a subcutaneous injection and should be monitored using anti-10A monitoring, although it requires a fondaparinux-specific anti-10A assay. Unlike the heparin products, there is no specific reversal agent indicated for reversal of fondaparinux. Next, we will move on to the discussion of oral anticoagulants. The first oral agent is vitamin K antagonist, or warfarin, which competitively inhibits the enzyme vitamin K epoxide reductase complex 1, and through this inhibition, warfarin depletes the reduced vitamin K that is a required cofactor for vitamin K-dependent coagulation factors, which include factors 2, 7, 9, and 10. Warfarin remains the mainstay for oral anticoagulation in the pediatric population. Warfarin has a narrow therapeutic window with a typical goal INR of 2 to 3 for the treatment of VTE, and INR should be closely monitored, especially when starting therapy, as it may take a few days to be at a therapeutic INR due to the delayed anticoagulation effect of warfarin. The effect of warfarin may be reversed using vitamin K, or in certain situations using prothrombin complex concentrate, or PCC, and the method for reversal depends on the INR as well as the degree of reversal we are targeting. Warfarin is advantageous in that it does not require renal dose adjustment, and thus may be the preferred agent in patients with an underlying renal dysfunction. However, it has many drug-drug interactions and should always be checked for interactions whenever starting a new agent. Use of warfarin can be especially challenging in the pediatric population due to age-related differences. First, warfarin is not available as a liquid formulation, although the tablets may be crushed and dissolved in water for easier administration. Second, due to age-related dietary differences with higher vitamin K content in formula, the dose may frequently be modified with changes in diet. Additionally, pediatric patients may often require administration of medications and feeds through a gastrostomy or jejunal tube, and as warfarin is absorbed in the stomach, the administration of warfarin should be separated from feeds by at least an hour. While many factors can affect warfarin dosing in pediatric patients, studies have found that age is the greatest determining factor, with infants requiring a higher mg per kilo per dose compared to older children. Lastly, it should be noted that while INR monitoring is routine in pediatric patients, the data is extrapolated from adult studies. Although direct oral anticoagulants are frequently used in the adult setting, the role of direct oral anticoagulants have not been fully established in the pediatric population, with many studies still ongoing. The use of direct oral anticoagulants is not yet outlined in the guidelines, but it is worth discussing with more agents being approved for use in pediatrics. Direct oral anticoagulants may be preferred for its ease of administration, as well as the lack of need for therapeutic drug monitoring compared to some of the agents that we have discussed thus far. Currently, there are 4 direct anti-oral coagulants: rivaroxaban, apixaban, and edoxaban, which are all factor Xa inhibitors, and dabigatran, which is a direct thrombin inhibitor. In this presentation, we will be focusing on dabigatran and rivaroxaban, both of which have an approved FDA indication for use in pediatric patients. Over the past few years, direct oral anticoagulants have come a long way in the pediatric population. In June 2021, dabigatran became the first FDA-approved direct oral anticoagulant for use in pediatric patients, followed by the approval of rivaroxaban in December 2021. Currently, there are ongoing clinical trials investigating the use of apixaban and edoxaban in children to establish pharmacokinetic, pharmacodynamic, and safety and efficacy data, and the results from these studies are still pending. We will start the discussion of direct oral anticoagulants by focusing on dabigatran. The use of dabigatran for treatment of pediatric VTE was studied in the DIVERSITY trial, which was a randomized, controlled, multi-center, non-inferiority trial that included patients less than 18 years of age with an acute VTE initially treated with parenteral anticoagulation, requiring at least 3 months of anticoagulation therapy. The study randomized patients to receive either oral dabigatran or standard of care, which included unfractionated heparin, low molecular weight heparin, warfarin, or fondaparinux to compare the composite efficacy endpoint of the proportion of children with complete thrombus resolution, freedom from recurrent VTE, and VT-related death. The results of the DIVERSITY trial show that 46% of patients in the dabigatran group met the composite primary endpoint compared to 42% of patients in the standard of care group. Further, when looking at the individual components of the composite endpoint, the incidence of complete thrombus resolution, freedom from recurrent VTE as shown on the graph to the right, as well as freedom from VTE-related death were similar between the two groups. Additionally, a safety analysis showed that dabigatran was similar to the standard of care group in regards to incidence of major bleeding events, as well as clinically relevant non-major bleeding events. In conclusion, the DIVERSITY trial showed that in patients less than 18 years of age, dabigatran was non-inferior to standard of care for the treatment of an acute VTE after initial treatment with a parenteral agent. Based on the results of the DIVERSITY trial, dabigatran gained FDA approval for use of treatment and prevention of VTEs in patients 3 months of age or older, with the pellets approved for patients 3 months to 12 years of age and capsules approved for patients 8 years to 18 years old. Although the pellets have been FDA approved, it is currently not yet available on the market for use. Compared to warfarin, dabigatran may be preferred for the lack of need for therapeutic drug monitoring. However, caution should be taken in patients with renal dysfunction. Although a specific reversal agent, idarucizumab, exists for the reversal of dabigatran, its use has not been fully established in the pediatric population. Here is a table of dosing for dabigatran capsules for patients 8 years and older up to 18 years of age, and it is important to note that the dosing increases with an increase in patient's weight, and thus the patient's weight should be closely monitored in a growing child and adolescent to ensure appropriate dosing of dabigatran. The table here shows dosing of dabigatran oral pellets for patients less than 2 years old. The dosing here is both age and weight dependent, and again, close attention should be paid to the child's weight. To the right is a dosing table of dabigatran oral pellets for patients 2 to 12 years of age, and here the dosing increases with an increase in the patient's weight. And it should be noted that the dosing is different from how the oral capsules are dosed. Here is a summary of pearls to consider when initiating a pediatric patient on dabigatran. First, initiation of oral dabigatran should follow at least 5 days of parenteral anticoagulation therapy. Second, it is important to remember that between the two different formulations of dabigatran, the dosing is not substitutable on a milligram-to-milligram basis, and one should pay close attention to the dose when switching formulations. Third, dabigatran may not be administered via NG or gastric feeding tube. Lastly, although not yet commercially available, currently the oral pellets are only approved for children less than 12 years of age, and it should not be mixed with milk or milk-containing products. The next oral anticoagulant we will be discussing is rivaroxaban. Rivaroxaban for treatment of pediatric VTEs was studied in the Einstein Jr. trial in 2020, which was a randomized controlled multi-center non-inferiority trial that included patients 0 to 17 years of age with an acute VTE initially treated with up to 9 days of a parenteral anticoagulation. The study compared rivaroxaban to standard of care, which included heparin or vitamin K antagonists, to look at the incidence of recurrent symptomatic VTE after 3 months of treatment. For patients that were less than 2 years of age with a central venous access device-related VTE, the treatment duration was shortened to 1 month. The Einstein Jr. trial showed that 1% of patients, or 4 out of 335 patients in the rivaroxaban group, had a recurrent symptomatic VTE compared to 3% of patients in the standard of care group. For the safety outcome of major or clinically relevant non-major bleeding, 3% of patients in the rivaroxaban group had a bleeding event compared to 2% of patients in the comparator standard of care group. Based on the results, the Einstein Jr. study concluded that for patients 0 to 17 years of age with an acute VTE, rivaroxaban compared to standard anticoagulation with heparin or warfarin had a similar incidence of recurrent VTE, and thus rivaroxaban was not inferior to standard of care. Based on the findings of the Einstein Jr. trial, rivaroxaban has been approved for use in patients from birth up to 18 years of age for the treatment of VTE or prophylaxis of recurrent VTE, as well as thromboprophylaxis for patients 2 years or older with congenital heart disease after a Fontan procedure. Rivaroxaban is available as a tablet or oral suspension, and similarly to dabigatran, does not require therapeutic drug monitoring and should be used with caution in patients with renal dysfunction. Although andexanet has been approved for the reversal of rivaroxaban, its role has not been fully established in the pediatric population. The table to the right here shows the dosing of rivaroxaban oral suspension as well as tablets for VTE treatment and prophylaxis in pediatric patients, and it is important to note that the dosing is based on weight and may be given up to 3 times a day in younger patients, which differs from the once-a-day dosing in adults as well as older children. The dosing differs when used for thromboprophylaxis after a Fontan, and the dosing table can be found in the package insert. To the left is an image of the syringe that is supplied with the rivaroxaban suspension, which is intended to guide dosing, especially for our smaller patients. There are a few pearls to remember when using rivaroxaban for a pediatric patient. Rivaroxaban should be started following at least 5 days of parenteral anticoagulation therapy, and should be taken with food to increase absorption when being used for treatment or prophylaxis of VTEs. Unlike dabigatran, rivaroxaban is advantageous in that it may be administered via an NG or gastric feeding tube. Due to the fact that dosing changes frequently with a change in weight, the weight should be monitored closely in a growing child. Lastly, there is a specific recommendation that an additional dose should be given if the patient spits up a dose within 30 minutes of receiving the previous dose. The next consideration in treatment of DVTs is the duration of treatment. For pediatric patients, the current guideline recommendation is treatment for up to 3 months of anticoagulation for provoked DVT or PE rather than a longer treatment course, and anticoagulation for 6 to 12 months for patients with an unprovoked DVT or PE. This differs from treatment duration recommendations in adults in the setting of an unprovoked DVT, where a longer anticoagulation treatment may be warranted. For pediatric patients especially, it is important to weigh the burden as well as risk versus the benefit of having an extended anticoagulation treatment duration. While the current standard of care has a treatment duration of 3 months for provoked DVTs, extrapolated from the adult data and recommendations, some practice guidelines have suggested a shorter anticoagulation therapy course of 6 weeks in the pediatric population to minimize the burden of anticoagulation therapy. However, there has been a lack of definitive evidence to support this recommendation, and thus the KIDS-DOT study aimed to compare a shortened duration of anticoagulation of 6 weeks versus conventional duration of 3 months in a randomized controlled non-inferiority trial in pediatric patients with a first acute provoked VTE. The primary outcome of the study looked at the net clinical benefit between the two treatment duration groups, defined as the 1-year risk of symptomatic recurrent VTE, as well as clinically relevant bleeding events. The study included patients less than 21 years of age with an acute VTE confirmed radiologically within 30 days of enrollment, with a known provoking factor for the VTE, which included recent hospitalization, traumatic injury, as well as central venous catheterization. Patients were excluded from this study if they had a prior VTE, an active malignancy, systemic lupus erythematosus, a pulmonary embolism, thrombotic therapy for VTE, or a clinically significant deficiencies of any anticoagulants. Patients were randomized to either receive 6 weeks of therapy or the standard of care 3 months of therapy, and initial treatment included the use of unfractionated heparin or low molecular weight heparins, followed by the use of a parenteral agent such as low molecular weight heparin or fondaparinux, or alternatively an oral agent such as warfarin or direct oral anticoagulants. The results of the study showed that the primary efficacy outcome of symptomatic recurrent VTE within 1 year occurred in 1 patient, or 0.65% in the 6-week anticoagulation group, compared to 2 patients, or 1.4% of patients in the 3 months anticoagulation group. The primary safety outcome of clinically relevant bleeding events occurred in 1 patient in the 6-week group compared to 1 patient in the 3-month group. In conclusion, the study showed that in patients less than 21 years of age with an acute provoked VTE, anticoagulation with 6 weeks is non-inferior to standard of care with 3 months of therapy when comparing efficacy and safety. Based on this study, a shorter treatment course may be considered for patients with an acute provoked DVT, weighing the risks and benefits of a shorter anticoagulation course. Lastly, we will discuss the use of DVT prophylaxis in the pediatric population. Guidelines published by the American College of Chest Physicians in 2012 outline a subset of pediatric patients that may benefit from the use of DVT prophylaxis. These patients include those with a cardiopulmonary anastomosis, use of prolonged home TPN therapy, primary pulmonary hypertension, presence of an endovascular stent, hemodialysis, or moderate or giant coronary aneurysms following Kawasaki's disease. Although recommendations for DVT prophylaxis in acutely ill hospitalized adults are clearly defined based on studies that demonstrated superiority of pharmacologic prophylaxis in reducing the incidence of VTEs in high-risk adult patients, there is currently no clear recommendations on which hospitalized pediatric patients may benefit from DVT prophylaxis, and data is lacking to support the use of pharmacologic prophylaxis. Studies in pediatric patients have focused on prophylaxis to prevent central venous access device-associated DVTs, which is the leading cause of DVTs in pediatric patients. However, no studies to date have shown superiority of pharmacologic prophylaxis in pediatric patients in preventing central line-associated DVTs, and thus further investigation is needed. Despite lack of definitive evidence, certain pediatric patients may benefit from VTE prophylaxis in the hospital setting, weighing the risks and benefits. When VTE prophylaxis is warranted, there are three approaches to prophylaxis: early ambulation, mechanical prophylaxis, and pharmacologic prophylaxis using some of the anticoagulant agents that we have discussed thus far. Early ambulation should be encouraged in all patients when able, as immobility can be a major risk factor for developing VTEs while hospitalized. Determining which hospitalized pediatric patients may benefit from prophylaxis to reduce the incidence of VTEs is not clear-cut. Based on practice guidelines from various hospitals and systematic reviews that have been published in the past few years, a certain subset of pediatric patients may be considered for prophylaxis. Those patients include hospitalized children greater than 10 to 14 years of age with certain risk factors. Patients with at least one risk factor or immobility may be considered moderate risk patients and may be candidates for mechanical prophylaxis. Those patients with at least one risk factor as well as immobility may be considered high-risk patients, and mechanical and/or pharmacologic prophylaxis may be considered. Again, unlike in the adult setting, the benefit of VTE prophylaxis has not been fully established in the hospitalized pediatric setting, and the use of prophylaxis should be on an individualized basis following hospital guidelines. When determining candidates for VTE prophylaxis in the hospital setting, especially for adolescent patients, underlying risk factors should be considered to assess the patient as a whole. Some of the main risk factors to consider include the presence of comorbidities such as recent surgery, congenital heart disease, infection, or malignancy, a previous DVT or VTE, as the incidence for a recurrent DVT can be up to 15%, and the presence of a central venous access device. A list of the full risk factors may be found back on slide 6. Pharmacologic agents for prophylaxis are similar to those that are used for treatment and agents that we have already discussed. For the parenteral agents of heparin and low molecular weight heparin, the dose is lower than what would be used for anticoagulation treatment, and although the anti-10A goal for prophylaxis has not been definitively established, a lower goal may be considered. Oral agents include the use of warfarin, dabigatran, and rivaroxaban, and the dosing can be found on previous slides. To wrap up the presentation, we will now test our knowledge with a few questions. Question number 1. Which of the following risk factors account for the majority of DVTs found in hospitalized pediatric patients? Is it A, malignancy, B, presence of central venous catheters, C, nephrotic syndrome, or D, trauma? The correct answer here is B, the presence of central venous catheters. While the other options are also risk factors for developing a DVT, a presence of central venous catheters has been found to be the biggest risk factor for DVTs in hospitalized pediatric patients, with greater than 50% of cases being associated with the presence of a central access device. Question number 2. Which of the following oral anticoagulants is available as a liquid formulation for use in the pediatric population? A. Warfarin, B. Dabigatran, C. Apixaban, or D. Rivaroxaban? The correct answer here is D. Rivaroxaban, which is available as both liquid and tablets. Warfarin is only available as tablets, and dabigatran is available as capsules and also approved for the oral pellets, which are not yet available for use on the market. Apixaban is currently not approved for use in the pediatric population, although the study is currently ongoing. Question number 3. A 2-year-old patient with a history of congenital heart disease and central venous access device presents with an acute DVT that requires treatment. Currently, his GFR is estimated to be less than 50. Which of the following agents do not require renal dose adjustment for this patient? A. Warfarin, B. Dabigatran, C. Rivaroxaban, or D. Enoxaparin? The correct answer here is A. Warfarin, which may actually be the preferred anticoagulant agent in the setting of renal disease. All of the other agents, dabigatran, rivaroxaban, and enoxaparin, require renal dose adjustment and should be used in caution in patients presenting with renal dysfunction. Question number 4. What is the current guideline recommended treatment duration for a pediatric patient with a provoked DVT or PE? A. Less than or equal to 3 months. B. 6 to 12 months. C. Less than or equal to 6 weeks. Or D. Less than or equal to 3 weeks. The correct answer here is A. Less than or equal to 3 months for a provoked DVT or PE as recommended by current guidelines. Although there has been some practice recommendations and studies that suggest a shorter 6-week treatment duration for pediatric patients may be adequate in certain situations. Patients with an unprovoked DVT should be treated for 6 to 12 months. Question number 5. Which of the following hospitalized patient would most benefit from pharmacologic DVT prophylaxis? The A. 14-year-old who underwent laparoscopic appendectomy, ambulating 1 day post-operatively. B. 12-year-old with central venous catheter-related bloodstream infection who has had the line removed. C. A 15-year-old with a history of obesity admitted after a motor vehicle accident requiring surgical intervention. And D. A 5-year-old with a fracture of the arm admitted for observation. The correct answer here is C. Patient A would not meet criteria for prophylaxis as the patient is already ambulating. Patient B would not meet the criteria as the central line has already been removed. Patient C here has several risk factors, including her age, a history of obesity, and immobility due to a surgical intervention. Patient D is 5 years old and does not meet the typical age range for when pharmacologic prophylaxis should be considered and also does not have any major risk factors. To wrap up this presentation, here are a few takeaway points on pediatric VTE treatment and prophylaxis. First, While the incidence of DVT is low in the general pediatric population, there is a higher incidence in the hospitalized pediatric population, with the presence of a central line being the biggest risk factor. 2. Current guidelines recommend the use of unfractionated heparin, low molecular weight heparins, fondaparinux, or vitamin K antagonists such as warfarin for the treatment of DVT in the pediatric population. 3. Dabigatran and rivaroxaban have both been recently approved for use in the pediatric population for treatment and prevention of DVT as oral anticoagulation options. And lastly, there is currently no clear guideline recommendations for the use of DVT prophylaxis in hospitalized pediatric patients. Here is a list of references, and this will conclude the presentation of pediatric DVT treatment and prophylaxis.